All right, thanks, Josh. Well, good morning, everyone, and happy St. Patrick's Day. I'd like to call the March Heartland Continuum of Care membership meeting to order at, what time is it? 9:03 a.m. And love this introductory screenshot here, Josh, because I was going to remind everybody to make sure that they signed in the chat box with their name and their organizational affiliation. So thanks for that. That's terrific. Are there any additions or corrections to the February meeting minutes? Well, if not, the minutes will stand as presented. We're excited this morning to have a presentation. It's Mental Health Mobile Crisis Response from Memorial Behavioral Health. And we have Monica Farquhar, Director of Community Access and Recovery, along with Leah Jones, Manager of Mobile Crisis Response, with us. Good morning, ladies. We're really excited to hear your presentation. It's a pleasure to have you here with us.
Good morning.
Good morning.
And Leah says she's having camera problems,
Oh.
so I have to look at my mug instead. So if we're ready to get started, I have a presentation that I will attempt to share my screen. So with me, we usually don't use Zoom, but just a moment. Oh, it says I cannot start screen share and while the other participant is sharing.
Try again now, Monica. Hopefully it should work.
Select.
Yay.
You seeing it?
Yes.
Wonderful. All right. And if you have trouble hearing, also let me know too, because I have a habit of getting through a presentation and someone says at the end, I didn't hear a word you said. And then I think, oh man, so please.
Oh, we'll let you know.
Okay. Well, thank you for having us. This presentation, some of it covers what is a crisis. It covers about Memorial Behavioral Health Services in general. So I might kind of go through some of the slides really quickly. But anybody who wants this slide, I did send these slides to Josh. So you are welcome to have this if you want to take it back to your agencies to share, or if you want to contact us to have Leah, myself, or Cassie Delaney come and talk with your group. Leah can contest, can say that we are having a road show. She and Cassie have been traveling all over the place talking about our mobile crisis response. So please don't hesitate to reach out to us if you want us to come by your shop. So what we are doing is we are embarking on an expansion of not just crisis services, but our whole continuum of crisis care. So in the past, Memorial Behavioral Health has always had crisis services. Our crisis services have generally been, they've consisted of coming to our office and we'll provide a crisis screen, going to the emergency department where our psychiatric response team was. We also had a SAS team that would go out and provide that mobile crisis response to individuals aged 20 and under. Sometimes our case managers in the community or our PAC case managers would get a crisis, would help start assessing a crisis and then bring them to our office or ER. But then it would kind of stop there. We would determine, are they at risk of harming self or not? Do they need admission or not? And so really our resources beyond hospitalization or follow-up with therapy services, those were kind of it. There wasn't really an in-between ground for people that they're not really needing hospitalization, they're needing something more than just outpatient services. So last year around this same time, the Department of Human Services that sent out a grant stating we're going to revamp our crisis continuum of care system, or we're going to develop a continuum of care. And they call it the 590 grant. Memorial Behavioral Health, we did apply for this grant and we received it. And so beginning in July, we've been steadily working on that continuum of care of what does that look like. And so we developed phases, and the first phase had to do with developing our mobile crisis response team. So like I said, we already had a mobile crisis response team, but it was just geared for those individuals that were CARES approved and were age 20 and under. And right now what we're doing is we're expanding all that. So as this slide says, it's a time for change. We have a person in crisis. What we're going to have is the crisis line. We have found that a lot of crises can be resolved via phone calls. 911 will be able to utilize this crisis line. The crisis line, if we can't resolve in person, we're going to send out our mobile crisis response team. Police can also access this mobile crisis response team. We can co-respond. And then we're going to look at our crisis facilities. So what we have found is a number of individuals that are crisis screened in the community, and we're also discharged. About 65% get discharged back into the community. So just Memorial Behavioral Health numbers alone, these are more national statistics, but just Memorial Behavioral Health numbers, just in our fiscal year 21, we did close to 600 mobile crisis response screens in FY21. And of those 600, 60% were deflected. So meaning they did not need to go to the hospital to have inpatient care. They could remain out in the community and get stabilized and receive outpatient services. So that's a pretty large number. And just think, if we didn't have that team to do that, they all would have gone to the emergency department because that was the only other place they could have a crisis screen done. So what we're doing is we're hoping that number will even be larger, because what we're looking at is not just providing screenings for individuals 20 and under, but for the full lifespan, so including our adult population. And then you can see that 85% remain in the community and they are community-based otherwise. So having follow-up services with our case management. Mobile crisis response will also provide follow-up services after the crisis event occurs. One of the things that we're looking at, including in our crisis continuum of care, is 988. So like developing a call center. And for those of you who haven't heard of 988, it's the equivalent to 911. It's just, it is specific to mental health crises. And so 988 goes live nationally, July 16th. And even though the Department of Human Services has not sent out the grant yet for Illinois, MBH is going to be applying for a call center grant. And since we're already a provider of the National Suicide Prevention Lifeline, we will be getting one of the call center grants. And so for this region, Memorial Behavioral Health will be hosting the 988 call center. And what would happen with this is a person calls 988. It's a real easy number to remember, and they can receive that telehealth crisis support. A lot of individuals that we have found that call the National Suicide Prevention Lifeline actually just want resources, and yet they don't know where else to turn. So they call that 1-800 number to get resources. And so 988 will also provide that. They'll provide resources and being up with those resources that can help an individual. 988 can also serve as our dispatch for the mobile crisis response team. If 911, we're working with dispatch, and also Department of Human Services is working statewide with 911 dispatch to see how we can work in conjunction with each other. And then also the National Suicide Lifeline will be absorbed by 988. So if people still continue to call that 1-800-273-TALK phone number, they're going to get a 988 specialist. And so really anything that is out of the person's usual and normal functioning, a heightened sense of awareness, of intense emotions. Really, those things create what we call a crisis state in a person. Anything out of their norm, where they're very uncomfortable or having emotional distress, is a crisis. So, a crisis to one person may not be a crisis to another person. But that's where the mental health professionals come into play, because we can help with that. We do understand that someone might be in distress over something like the loss of a pet, which can be very distressing to individuals, particularly if that's kind of their lifeline. If you think about it, a person walking their dog, they socialize, they see other people walking their dogs, and you get to learn, your neighbors that way. And so when you lose that pet, you also lose a social lifeline as well. And yet to another person, that might not seem like a crisis, and enough to warrant, calling a national hotline for help. But mental health professionals, we do understand that, and so we know how to look for what the warning signs are, in how that person is responding to whatever happened that created that crisis state. So are they isolating more? Do they seem to not be sleeping well, so that maybe they're losing touch with reality? They're not eating well. They're having more mood swings. They're getting angrier more often than they usually do. What we hope to do is we hope to reduce that stigma to services. So what we think often happens is we do think part of the gap in service is created, particularly by certain populations, because they don't have a trust in the mental health system, or they've not had good experiences or really known how to access it or been encouraged to access it. So we really want to help reduce that stigma to accessing mental health services. So we don't want to put a label on mental illness. We don't want folks to be afraid of people with mental illness. You can't even see mental illness, right? So how do you know that the person you're standing next to isn't suffering from depression? So we want folks to be sensitive with individuals that are suffering from mental illness. And in fact, we're moving from calling it mental illness to looking more at individuals' mental wellness. In fact, our National Council on Mental Illness recently changed their name this past year to National Council on Mental Wellness. 1 in 5 adults experience mental illness in a given year. And so 20.2 million adults experience substance use condition, and 50% of those also have a co-occurring mental illness. Something that might be of interest for this group is 46% of homeless adults staying in shelters also have mental illness and or substance use disorder. 70% of youth in juvenile justice systems have at least one mental health condition. And 60% of all adults, almost 50% of youth with mental illness received no services in the previous year. So this is also another national statistic that African Americans and Hispanic Americans used mental health services about half the rate of Caucasian Americans in this past year, and Asian Americans at about a third of that rate. And so we're definitely seeing where that gap is. And a lot of that we think does have to do with just it hasn't been accessible to them. There is stigma attached to that. And it's there's a lack of trust in that system, in the health system. So we're hoping that expanding our crisis continuum of care, having our mobile crisis response teams be out there, be more in the community-based for all populations, regardless of payer source of insurance, regardless of age, regardless of where they're located. We're hoping that that can start to help reduce that gap, because then that mobile crisis response team will also do follow-up with them and try to make sure that they're getting linked with those services. So they're going to try and start to establish that relationship. So mobile crisis response is just how it sounds. It's a crisis response team that's mobile. It's going to come to you in the community. How it will look at first is we'll start off with a telephone triage. And again, I know there's a demand for in-person service. We keep hearing we want in-person, and this is an in-person team. But what we have often found is a lot of times when we call and talk with the individual, it can get resolved by the telephone. And if they need more, if they need that in-person level of care, then we will provide that in-person crisis response. But we're going to always start it off with a telephone triage to see how they're doing, but then also to assess the level of crisis, because maybe they need to be linked with the emergency department. Like if we find out through that telephone call that they haven't had an overdose, we're going to want to make sure that they're physically okay. And so we're going to get them to the emergency department. So it's not that we're never going to call 911. We're often going to be working alongside our law enforcement. But our main objective through that telephone triage is to assess for safety first. Are they safe in their current place, their current location, or do they need to be in a safe place? And then we'll provide that crisis response. We'll do stabilization. If we are unable to stabilize in the community, then we will assist in getting them linked with that hospital care. And then also we'll provide the follow-up. So what we find is after the crisis has been resolved, for that moment, sometimes that crisis leaves them more vulnerable. And so we want to make sure that we are following up with them after the crisis event occurs. Also, to make sure that we're getting them linked up with the resources they need. The people that are often going to be linking with individuals after the crisis occurs will be our peer recovery specialists. So people who have walked a mile in their shoes, people who have experienced mental health, who've experienced hospitalizations or drug use or problems with law enforcement. So our peers are really going to be vital and key partners in being able to help make sure that we're connecting and meeting with individuals. So we're trying to increase access to behavioral health care. We're increasing our crisis services. We're taking referrals and getting them to the appropriate behavioral health services that are needed. And we're increasing that continuity of health care across our communities. Our goal for our MCR mobile crisis response team is to reduce the overall emergency room visits due to the behavioral health needs. And in that, we're hoping, that people will want to utilize the mobile crisis response. We think sometimes people are in crisis, but they don't do anything about it. And they try to handle it on their own, all alone, and they don't have to. The number of times as a therapist, I would hear a person tell me that they were thinking of taking their lives, but they didn't call anyone and they didn't go to the hospital because they didn't trust that system. They didn't want to get admitted. They didn't think that the person sitting across from them would really listen and understand them. And instead, we want to take their rights away and force admission. And that always concerned me as a professional. Because I wanted to make sure that they didn't feel alone, that they did feel comfortable with their crisis team, that they would listen to them and support them. So if we have a mobile crisis response team, that kind of takes away that fear of having to go to see a doctor who might not listen to them or understand them, because they're going to have peer support, they're going to have a mental health professional that's going to come to them. We're also hoping to reduce inpatient admissions. And if we have to have inpatient admissions, hopefully they would be more short term because we're going to have the appropriate follow-up resources and then connect people with the right community resources to help them stay stabilized. So right now, our mobile crisis response team at this very moment is still serving that traditional SAS population of age 20 and under. But come April 4th, That's going to be our go live date for our St. and Menard region. We will be opening doors to all individuals, regardless of care source, regardless of age. And that our CARES line no longer needs to be called. In fact, in the next slide, you're going to see our phone number. In fact, we would prefer that you just call our mobile crisis response, and we'll handle anything that has to be CARES related on the backside. So for our MCR, we're going to be providing that to our St. Menard, Morgan Scott, Logan Mason, and Christian counties. Like I said, April 4th is going to be our go live for mobile crisis response in St. Menard. Come June, we'll go live in Morgan Scott. And in July, we'll go live with our Logan Mason. And Christian will be in next year's phase. So we already talked a little bit about this. A mobile crisis response screen would first start with telehealth, where we would call and do a telephone triage. We would then see if an in-person response is needed. We would provide peer support. If we need to have hospital services, then we're going to connect with our PRT team. And we're all in the same agency. So our mobile crisis response and our psych response team, who are located at the emergency departments in our communities, they will be working hand in hand with each other. We're going to provide the follow-up support, which includes safety planning and then a connection to resources. So if you do have a person that does need to be admitted or you think is not safe to remain in the community and they really do need to be in a safe place, the emergency department still is a very safe place to go. And we have worked so hard with our emergency departments, St. John's, Springfield Memorial, Taylorville, Lincoln, and Jacksonville, that they do have a better understanding of mental health needs. And they also know that they have the psychiatric response team, PRT. So they oftentimes make an immediate referral so that it engages PRT to come to the emergency department. Our PRT team is full-time now, and they are located at the emergency departments 24/7, 365. Our MCR teams are also full-time, meaning we're trying to reduce the number of on-call we have to do, so that our crisis teams are truly experts in providing crisis service. This is what they do: PRT, crisis clinic, MCR, mobile crisis response. They don't have secondary jobs. They're not therapists who sometimes moonlight as mobile crisis response. This is what they do. So they are experts in handling crisis situations. Not to say that we still don't have folks who want to take on call. We do have therapists and case managers who want that experience with crisis care. And so we do still have them on our own call team when we need on call. So we have different programs, and I won't go through each one of these because if you get a copy of our slides, you can see a number of our programs that we have that we refer individuals to and try to connect them with through our adult services. We have a number of community programming. We have our living room. Memorial has a partial hospitalization program for adults. They do have an inpatient psychiatric unit. For children's services, we have case management, we have walk-in services. Leah has just created a community support team for youth. We've had them for adults for years. And in April, we're going to be going live with our community support team for our youth, which will provide more intensive youth services in our community. And then these are further services that we provide at Memorial Behavioral Health, a first episode psychosis. So individuals that have their first psychotic break. That's often a very delicate time, and it often gets missed too when it does happen. And yet it's a very critical time to get that person engaged in services with therapy, case management, medication. And then we also have a family support program for our youth who need higher intensive services such as residential services. So we're hoping that we do develop more mental health awareness by increasing our crisis continuum care. We want to increase mental health knowledge. We want to promote mental wellness and reducing that stigma. We want to provide support in our community. We take a trauma-informed care approach to our crisis services, as well as our just our regular services in general. And this is probably a very exciting thing that I think you guys will enjoy hearing. But our future plans is developing a mental health urgent care. And we have been planning, we've been business planning, we've started looking at what it would look like and location. So it's a regional crisis call center hub, and it will respond to the 988 calls, providing intervention, emotional support. It will house our mobile crisis response teams, our living room and care recovery specialists, and it will serve as crisis receiving and stabilization center. That will provide short-term crisis observation beds, sobering beds, and triage. So we're looking at having also longer-term crisis stabilization beds and potentially down the road some detoxification services. So the urgent care is not going yet, and it might be like in the next year or so. But the planning is there to have not just the mobile crisis response and what we've had in our living room, but to now have that even added resource for those individuals that kind of fall in that gap. They don't need hospitalization, but remaining at home might not be the best option for them at that moment. Can they go to a crisis receiving stabilization center? Can they go to our urgent care? And at our urgent care, then it would be determined what level of services do they need. Do they just need to talk to someone in our living room? Are they sobering? Yet, they're needing to sober in a safe place. And so those are some of the things that we're hoping to offer in the future, the near future. I want to make sure you have our phone number. So this is our mobile crisis response phone number, 217-788-7070. That phone number is not active right now. It goes live April 4th. So if you call now, you're not going to have anything, but if you call April 4th, then you will get a mobile crisis response specialist. And if you do want someone to come and talk to you, Leah Jones, manager of our crisis response and community recovery services for children, is available, as well as Cassie Delaney, who's our project director for our crisis system of care. Do you have any questions? I know I threw a lot at you about mobile response.
I just want to say thank you, Monica. I'll start with that. But there's a lot of content there, but it's incredible to see the work that you are doing. And as these programs hit the ground, it's going to make a big difference here. So just want to say thank you.
Having worked in my capacity for 30 years, plus 30 years, I have just seen so many adolescents. Right now, I get calls daily on these adolescents that are showing up at the emergency room, being sent back home. I think the pandemic has made this much worse, but the extreme behaviors I'm seeing out of these kids, the violence, it will be good to see. Some of mine are in these outlying counties and outlying areas. It'd be nice to see this in action, and I look forward to working with you guys.
Thank you.
And I just want to echo Josh's comments too. This is phenomenal. There's a lot of information. Thank you for sharing the slides. I'm sure we'll be able to go through that again and look at it a little more carefully. One of the things you talked about, you said there were full-time, but does full-time mean 24/7 access? Okay, all right.
365. So it could be Christmas morning. We would hope a crisis wouldn't occur, but it could be Christmas morning and someone is going to be available to respond.
And my other question is, what about insurances and things like that? Is that a hurdle that we'll have to look at, or something like that? Okay. Because that was always a challenge in the past. And, I've had some experience with that. And that's just something that a lot of times can just stop something, that process moving forward, or there would seem to be a disconnect. So that's really exciting to know. I was also curious about, staffing. I mean, we all know how hard it is to get anyone, caseworkers, anyone like this. So are you having any challenges with that, or just curious, or are you being able to staff up pretty quickly?
Yeah, I can talk to that.
In our Sangamon and Menard County, for this team, I currently have 19 people on the team. I actually wrote the schedule yesterday, and in a 6-week time frame, everyone is on call a maximum of 3 times. So they're on call roughly every other week for 1 shift. The rest of the shifts are all covered by our full-time team, and we still have open positions. So the more full-time people we get on the team, obviously the less on-call need there's going to be.
Oh, that's fantastic, Leah. Do you have anything additional you'd want? I mean, Monica gave us a lot, but is there anything you'd like to add?
I think I have been asked the insurance question before, and people do want to know, yes, my client might have private insurance, and we are not going to bill that private insurance. So it does not matter if they're self-pay, no insurance, Medicaid, it doesn't matter. We'll get reimbursed on the back end for Medicaid, but we won't be reaching out to their insurance company and trying to collect payment or anything like that.
Terrific. Great. Anybody else have any questions? Like I said, I'm sure as I go through it again, I'm going to have a bunch more questions, but those were top of mind.
And that's the same thing with the urgent care that we're looking to develop. We're not looking at having it be focused on a person's insurance. So because that has been the biggest barrier to the services is insurance, and then all the paperwork that has to get done in conjunction. So we're trying to reduce as many barriers as possible.
We'll email out the video of this meeting, so it'll include this presentation and the slides to the whole general membership too. So if folks, you'll have access to those numbers, the emails, all of that Monica shared.
Okay. Well, if there aren't any additional questions, thank you so much. We really appreciate this presentation this morning. I think it's very timely. We all know what the change in mental health care many years ago meant to us. And so now I love that it's time to change that model. So thank you so very much.
Thank you for having us.
All right. Our emergency housing voucher update. Nick, could you fill us in here?
Absolutely. Hey, everybody. Thanks again to Monica and Leah for speaking about that awesome program. I'm really excited about that for Springfield. My name is Nick Dodson. I'm the housing navigator for the Heartland COC. In case you haven't met me, most everybody on here looks pretty familiar, so I don't think there's any introductions necessarily needed. We are up to 34 total vouchers activated in our community, with
Awesome.
18 clients fully housed since August 30th when I started, 11 waiting on inspections, and 5 needing units. So effectively, we're kicking butt and taking names, honestly. And if you look at the data on the national data, we are sitting at the national average of utilization of these vouchers is about 20%. Springfield Housing Authority and ourselves are at 35%, and that's actually higher because the most recent data isn't there. So I think that's really exciting to acknowledge. Further, we are in 6th place of 16 housing authorities with these vouchers in Illinois. So we are just doing great. I want to say thanks to everybody I've worked with, all the case managers, all the different organizations. You're just wonderful. I appreciate it. And, that's pretty much the report for the most part, I think. I don't think I've got anything else.
Okay. Thanks, Nick. We appreciate it. And we appreciate you and all your hard work. I know getting out there, getting landlords has kind of been your push for a while. And, you know, he's doing a phenomenal job doing that. So we thank you very much for all your work.
My pleasure. Thank you.
Hey, Nick, are you not going to brag on the fact that we pretty much can fill them all because we are waiting on some applications that are going
Right.
to finish it off for us? So
Pretty much. Yeah, we are pretty much effectively there. I'm just waiting for the last ones to come in to an extent to see if anything doesn't line up. But otherwise, yeah, we should pretty much effectively be there.
He's trying not to jinx it, Tracy.
Right. Yeah, that was that was exactly it. Because as soon as I say it, I'm gonna have 3 phone calls that departments didn't work out, or you know what I mean. So appreciate it.
Well, nice to have that little thing in our ear to know. So thank you. The strategic planning update, Josh.
Thank you, Val. And just I put a link in the chat, which has there was an email that went out to everybody who subscribed for the strategic planning emails in February. And then there was an Illinois Times article that came out a couple of weeks ago, and those are posted on our website. So if you go to that page, that's where we're posting updates on the plan as we have something more tangible to share. In terms of where we're at, the steering committee in the meeting for this month in March really spent time digging into what would it take to implement the strategic plan. So we've done work around what the draft goals would be. We've put together a special subcommittee to focus on how behavioral health and other supportive services, how we can create better processes and increase, you know, either both the resources that are available, or how we maximize the resources that already exist. And then we've had another group meeting to look at the needs around housing. How can we really improve what's available in terms of housing programs? So all of that has sort of led to a point where we have draft goals on those 2 areas. Some of that would include community education. How do we address NIMBY type of issues? Additionally, there's another area of focus, which has been on how to address unsheltered homelessness. So how does that impact our emergency shelter system, outreach, and those types of things? So that's in terms of content areas. Those are the key areas of focus for the strategic plan. With this meeting this month on what would an implementation body look like, how can we actually pull the players in place who can help us not just put together a strategic plan, but have the resources to actually create new programs and better resource our agencies. That was a great conversation. So with all of these steps, we're getting closer and closer to the point where we'll have a draft ready to go. I know as you hear these updates from month to month, it can feel like I don't know what's going on with the plan. It's just really hard to share out some of that in a way that feels pretty tangible. But as we get the draft in a place where it's ready to share, that's going to create a great opportunity for us to really converse about what the plan entails and get feedback on that as we create the final draft. So increasingly, we're getting to a point where that's the conversation we're going to have as a community. So I'm excited about that. Yeah, I think we had always said late spring, early winter. I think we're on the last week of spring, so obviously we're not going to hit the late spring part. I'm sorry, late winter, early spring. You know, obviously winter is almost over here, so it's definitely going to be in the spring. But there's just been a lot of incredible work, I think, that's gone into it, and I'm excited about both what the plan is going to include, but also the opportunity it will have for more resources to come to the table to create the care we know needs to exist in the community. So, any questions about any of that?
No, but Josh, if either you or Amy would elaborate a little bit more on this exercise we're doing in the for the housing group, I think that will show that we're really digging in, even though it's not out there. If you just kind of speak to kind of this exercise that we're working on with that group.
I'll take first run in it unless Amy wants to jump in, and then Amy can clean up anything or value to. We've got several people on the call who are part of that group. But you know, out of the housing subcommittee work that we did around what housing resources do we need as a community, one of the things that it wasn't entirely a surprise, but one of the things that we know is that our community lacks capacity to create additional units of permanent supportive housing or rapid rehousing. And there's a variety of different approaches. One approach would be landlord engagement. So with Nick's position as the housing navigator, our community has taken some significant steps forward in developing those landlord relationships. Another approach is, how do you actually leverage funding that exists out there to create units specifically devoted towards, providing permanent supportive housing or rapid rehousing. So once we got to the end of that housing subcommittee, the group decided, hey, we want to keep meeting and talk about some real properties that exist in our community. It's not uncommon for people to reach out to us and say, here's a property. Could it be used to help as it pertains to homelessness? And a lot of times we're like, yeah, that sounds great, but how on earth, how on earth do we actually not just have a conversation, but have that lead to real resources that are available for people who need housing? So that group now is focused on one property and sort of saying, okay, here's a potential property. What are the steps that we need to go through as a community? And what do we need to have in place so that when somebody brings a property like that to our attention, we can actually run it through a process and hopefully get it to the point where it's a fundable project that can lead to additional housing units. So I'm really excited about it. It's a tangible exercise out of, these processes sometimes can feel like theory and principles and,
Yeah.
and I think that's always the implementation part is always the concern out of a process like this. How does this actually change our community? And so, so this exercise that housing subcommittee is doing is exactly that, right? I mean, it is an exercise. It's not actually going through the paces, but it possibly at the end could lean to a real project. So
That was exactly my point, is I wanted to show there's some practical things that are happening, within, like you said, not just this, on paper and thinking about it. Amy, did you want to add anything more?
No, I think Josh covered it pretty well. Thanks.
Okay. All right. Thank you. Okay, the HUD COC competition award report was included in your email that for this meeting. And we just want to note that our funding stayed pretty much the same for this year, but we did want you to know that we did apply for additional funds, but unfortunately was not awarded those funds this go around, but we're going to keep plugging away at it. And I don't know if there's anything more you want to add to that, Josh.
Yeah, I mean, I think it's just helpful for our community to understand just, what Val said is right. We every year we have to apply, go through this pretty in-depth process through HUD. Our community is grossly under-resourced, frankly. In 2010, we were receiving $650,000 a year. We are now down to $400,000 a year. If you think about somewhat comparable communities in Decatur or Bloomington, Peoria, these communities are getting double what we're getting, in some cases triple. So it really is, it's a situation where frankly, as a community, HUD has basically said, hey, look, you haven't followed the strategy we want you to follow. And so gradually they've taken more and more funding from us. And then as a community, as we try to transform our system, we just have to recognize that that's where we're at. We've gotten to this place where HUD has basically punished us. We're in this place where we have over 200 people on our coordinated entry list. Over 100 of those need permanent supportive housing. Almost 100 of them need rapid rehousing. And the resources that come from HUD are not coming, right? So what we need to happen there, we have to recognize it's going to be some time before HUD begins to increase the level of funding in our community. And that has to do with federal politics, right? Does HUD actually get more funding for the COC program? If they don't, that makes it even harder to get additional HUD funding. It means that we have to become a higher performing community and essentially take that funding from a lower performing community. And in order for us to become a higher performing community, we've got to create more permanent supportive housing and rapid rehousing and see more movement from our coordinated entry list into permanent housing. And then we need to see people not just stabilizing, but successfully navigating those programs. So this is a lot of what the strategic plan is working to dig into. It's a really unfortunate place for our community to be in, frankly. It's a really unfortunate reality for people who are experiencing homelessness in our community, because we all know the resources that they need simply don't exist at this time. So, so it creates this space where, as a community, how do we move forward, right? we had an incredible grant application for a new rapid rehousing program that was a part of our grant this last year. It was something that our community desperately needed, right? And HUD didn't fund it. So as a community, we have to say, okay, we know those are the types of programs we need. How can we fund these programs? And so our hope is that the strategic planning process helps the wider community understand that as well, and eventually leads to the opportunity to leverage different types of funding sources. And then as we do that, let's say that rapid rehousing program, it didn't get funded by HUD, but is there a faith community out there that would fund it? And if they did, what's going to happen is there will be a demonstrable change in our data, right? HUD will be like, wow, somehow this community is actually housing people, even though we're not giving them a fraction of what they need to do that. And then as our data improves, then we have a much more competitive grant application that could then be used to leverage more funding. So there's a lot to that, but I think we just have to understand that that's where we are, and it's an incredibly difficult place to build from, but that's what we have to do. So so just want to throw that out there for free, but any questions or comments on that?
Josh, do you know if our score went up at all?
We haven't got our scorecard yet, so our HUD rep thinks we should see that in the next 2 to 3 weeks. So
With the projects being put in tier 1 and tier 2, usually HUD announces tier 2 at a different time than tier 1. Do you know if they were announced together this time?
They were, yeah. That was all.
Okay.
The funding announcement was for all of it.
Darn.
All right, thanks, Josh. We have a trauma-informed care training opportunity, so we're just asking you to save the date. We'll be partnering with SIU Survivor Recovery Center to host a virtual trauma-informed care training on May 11th from 1 to 4 p.m. And the registration information will be coming soon, so watch for that, if you will. A community ambassador training for those of you that have not had the opportunity to review the information. We hope you'll find some time to help us by being part of the solution for homelessness. And please share with anyone you believe might be interested. A link was included in your email, and hopefully by now you've all heard of this, heard about the numbers. Is Ronnie on, or anyone from the education team on?
Ronnie's not, but I just want to jump in and share a couple things there. One piece, we've now had over 100 people take that training. So that's, 100 people in our community who have devoted probably at least an hour of time to going through all of that content. And just as a anecdotal evidence why I think it's important for you all to take it and share it widely. I gave a presentation for a community group last month and happened to sit next to a business owner. And that person was saying, look, we have open positions. What would it look like for us to be able to do something helpful here? And as part of the presentation, I talked about that community ambassador training. That business owner took the community ambassador training, reached back out and said, hey, I want to talk about how I can actually employ people that are in shelters who might just, who need that opportunity. And had a meeting yesterday with a couple staff members from an agency and that business owner who is now working to figure out how to actually bring, create that employment opportunity. So just a quick story to say, I think it seems to be a really helpful resource, and it's helping to add more tools to our tool belt. So just want to encourage you to check it out and to share it.
Yeah, thank you for sharing that, because I think that's one of the things that we don't do enough of, is share those kind of stories out there. And I think we need to keep doing that a little bit. So kind of on that vein, it wasn't on our agenda, but I wanted to give a big shout out to the Education Committee on the monthly ambassador newsletter. Wow, what a fantastic resource. I just was amazed at all the information that was included on that. So kudos to them. Our general membership renewals is another reminder. We talked about this last month. We're just asking that everyone wishing to remain a voting member or organizational member of the continuum of care, that you update your information through the link provided in the membership email that was sent out earlier. Are there any agency updates to be shared with our members? membership?
Can I jump in real quick, Val, for
Sure,
HMIS? Okay.
sure.
So in my HUD monthly, we have an admin meeting. We discussed many things. They've been pushing security lately of client data. And this can, go across people who are doing electronically and who are not doing electronically also. They just really, they want to stress that if you're doing everything online, that's fine, but make sure you're logging out. Make sure you're just being very much aware of who can see your computer screens, say like in any setting, whether it's a shelter or if it's a permanent, if you sit down and you're having a case meeting with somebody and you forgot another client's information's on the screen. There's just, I guess, a lot of issues surrounding those types of things. Also, if you have paper copies of your clients' datas, they really want you to make sure you're locking them up. That those need to go in a locked filing cabinet or a locked desk drawer, or behind in a locked closet, not just, oh, it's over there on the filing or on top of my filing cabinet, and I'll get to it whenever. They're just really stressing the security. And another thing, especially with summer coming and a lot more of people being maybe in outreach on the streets, helping people. We're using these a lot more to access things, to make notes, to do a lot of stuff, whether it's an iPad or your iPhone or an Android or whatever electronic device it is. Something they said to make sure of is everybody needs to go into their Find My apps or Find My Phone app side of it and make sure you have the remote erase function. If that phone happens to get stolen on you, there's potential data on there for a client breach or client data breach. All Androids, all iPhones, all versions have this option available through their Find My Phone app. So just something to think about, those of you who are out in the field or, do a lot of client data collection, maybe on your phones or iPads or even laptops or, that's pretty much
Okay.
all I have. Just
Okay, thanks. Thanks, Tracy. Any additional agency updates, any events coming up, anything you'd like to share with the membership?
We have some positions open for truant officers. There's probably 3 more positions that are going to be filled, and we have had only 5 applicants and haven't found anybody yet to fill those positions. So we're in desperate need to get them filled. So if anybody knows anybody, let me know.
Okay, thank you. Anyone else? All right, our next meeting.
Sorry, I
will be-
was a little slow
Oh,
to unmute. I'm so
That's
sorry.
okay. Go
So
ahead, Susan.
Susan from SHPA. Our advocacy efforts are still underway. I'm going to drop a link in the chat to our SHPA's advocacy page. We're continuing to work with the statewide task force. There's a lot of listening sessions coming up. I'm sorry, I don't have the exact dates in front of me this morning. I'm a little bit on the go. So anything you need to know, please contact any of us at SHPA and we can connect you with some of those sessions that are happening, as well as any advocacy efforts still continuing until the budget supposedly is supposed to be approved in early April. So we'll cross our fingers. Thank you.
Okay.
Susan, thank you, Susan. Also wanted to say, if we have anybody from the veterans team that might be able to give an update on the stand down, that would be awesome. If not, we'll.
This is
Oh, there he is. Sorry.
Yeah, it took me a while to get unmuted too. I don't know why, but we did cancel the stand down that was scheduled for April the 1st because of coronavirus and lack of participation and fear of agencies not being able to show up for it. So we're just going to plan for a bigger one in 2023.
Yeah. Okay. Thanks, Archie.
Okay. Thank you, Archie. All right. Want to make sure I give everybody a chance here to unmute. All right, thank you. Our next meeting will be April the 21st at 9 a.m. May I have a motion to adjourn?
I'll make a motion.
Okay, I was gonna say, we can just stay on if we want.
Second.
Second, thank you, Juan. All in favor signify with a thumbs up.
Aye.
Everyone have a wonderful day, a great St. Patrick's Day, and stay safe and healthy.
DES
All right.
crew, stay on, please.
Yep, you are way
I
ahead
didn't
of
want
me.
Josh to hit that button.
I want a reminder that there is a coordinated entry meeting following this meeting. So thanks,
Sorry.
everyone.
Sorry, Val.
That's okay.